So hello and welcome everyone. We are going to be talking with you about the TIARA program. My name is Maggie Padek Kalman. I am the Director of Evaluation and Implementation Science at Frontiers Clinical Translational Science Institute. Then Dr. Danielle Olds, you want to introduce yourself?
I am Manager of Outcomes Research at St. Luke's Hospital and also Director of Training and Education at Healthcare Institute for Innovations in Quality Technology.
So just going to be all heads up of how we're going to do this. We're going to walk through a lot of content. This is kind of a higher level overview of the TIARA program. So there's a lot more details, a lot more resources that are actually covered in the actual course itself. We're giving you a very kind of sneak peek at what it is. We're going to walk through all these modules up front, and then that'll leave us time at the end if we want to go back and kind of discuss certain aspects, but just making sure that we cover everything within our presentation. Discussion. So I'm going to kick it off by giving you an overview of training and the impact that we've had. Then Dr. Olds will walk you through, and I will walk you through each of the modules, give you that high level overview, and then again have opportunity to ask questions at the end. So just a little bit of background, the Healthcare Institute for Innovations in Quality is located at the University of Missouri, Kansas City. The Institute provides education through the TIARA program, which is the focus of this presentation. And the mission of the Institute is to improve healthcare within the Kansas City region. And that is done through several regional quality improvement projects that have been determined based off of community input. And then the Institute hosts bi-monthly IQ forums, correct? Okay, which provides an opportunity to bring together both public, private stakeholders who are engaged in addressing specific health issues within the region. And the High IQ and TIARA program is also supported by Frontiers. So the work of High IQ is based on implementation science concepts, but what we have found is that traditional implementation science is often very inaccessible for clinicians. As you heard this morning in Paul's presentation, there's a lot of theories, frameworks, and methods which can be overwhelming. The projects using traditional implementation science really requires a lot of expertise and can be time-consuming. But at the same time, traditional quality improvement often lacks rigor. It doesn't often account for context, and there is really a lack of quality improvement methods related to the actual how of implementation. So, which led us to the development of the TIARA program. TIARA is meant to bridge faster, more effective health improvement programs. TIARA provides healthcare organizations with a proven framework for staff and clinicians to rapidly implement evidence-based healthcare improvement strategies. TIARA focuses on integrating QI and implementation science to make research more actionable in clinical and community settings. And based on established implementation science and QI competencies that have been used in several other training programs. And then the goal of our program is to have both the QI and implementation science clinicians and practitioners using the same language to promote for efficient change and outcomes. So real quickly, the TIARA program aligns with many of the goals of both Frontiers CTSI and the CTSA program by providing accessible training formats for both scientific and practice community. We have also been mindful to map how the program maps to the translational science principles, and you'll see how many aspects of this program apply to those principles. They're on the right. You're on your right. The overall goal of the program is to provide efficient and speed in the translation of research and evidence. And the program was developed when we recognized an unmet need in implementation science and QI training formats. So TIARA provides a flexible modular approach to fit your unique needs and program implementation. So whether you are targeting chronic disease prevention, medication adherence strategies, or clinician adoption strategies, TIARA provides customized tools and frameworks necessary for success. Our program can support the design, rollout, and continual improvement of your initiatives. And so while we do have several toolkits that are covered in this program, today we are just going to be focusing on the QIPI A3, which is the handout that we have given to you all. And that is a framework that's highlighted on the left-hand side of the screen. So TIARA is offered annually. We do have a virtual and synchronous option. We are currently in our 5th cohort of TIARA. It consists of 7 modules that are live with a virtual learning lab every other week. And then there is a virtual asynchronous that you can take a self-paced, again, 7 modules, and you can sign up for the asynchronous version at any time throughout the year. However, the live version, synchronous version is currently only ongoing during the spring. And so we have also custom tailored the TIARA program for specific organizations. Since its inception, we have trained 4 cohorts. Sorry, this says 3. And we're currently in our 5th, which have consisted of over 80 scholars that represent both researchers, practitioners, and clinicians. And then overall, we have seen really high levels of satisfaction with the program and are currently working on some long-term evaluation outputs. As you can see, we've had a cross-country reach with our attendees coming from many different institutions from different states. Our attendees have used this program to help with their community engagement projects, breast cancer mammography uptake, and even helping in the submission of the relevant R01. And this past summer, Danielle and Stacy and John all traveled across the world to Australia, to the University of Adelaide to present a custom version to investigators there. Yeah. So then I'm going to hand it over to Dr. Olds, who is going to walk us through our first section.
Right. So the first thing that we cover in the TIARA program are some of the basic principles of implementation science and quality improvement. So to start off, it's important to define what quality improvement is and what implementation science is. So this is the from the Batalden and Davidoff article on what is quality improvement and how can it transform healthcare. They define quality improvement as the combined and unceasing efforts of everyone to make changes that will lead to better patient outcomes. And the U.S. Department of Health and Human Services defines it as systematic actions that lead to measurable improvement in healthcare services and the health status of targeted patients. Implementation science in practice. So implementation science is the study of the methods. Practice is the, okay. Oh, sure. Okay. And then implementation science is the application of evidence that emerges from implementation science by people with the skills and the competencies to tailor implementation science frameworks, strategies, and approaches. And so this is a nice model by Mitchell and Chambers of sort of this like landscape of health services research and sort of where different, I don't want to say subspecialties, but sort of different domains within health services research fits. And so we really think of implementation practice as sort of bridging this gap between quality improvement science and quality improvement. So this is a model from Nielsen that Paul Esterbrook showed this morning, and it describes the different process models, determinants, frameworks, theories that sort of fall under implementation science. So process frameworks are used for describing the process and really provide sort of a map to guide you through the process of implementation. Determinants frameworks center around understanding and explaining what influences implementation outcomes. And then evaluation frameworks are used to understand the effectiveness of your implementation and the outcomes of the intervention. And so first we start out thinking about process models. So there's a lot of different process models and frameworks, and they guide and support the planning of the implementation. EPIS, the VA query roadmap, for any of you who ever worked in the VA, that was commonly used there. IHI model for improvement, logic models, which Paul also talked about this morning. We developed for TIARA a process model that we call the Quality Improvement Project Implementation Model. This is based off of a traditional quality improvement model called the A3. We modified it so that we could fit in principles from implementation science. We took this approach because a lot of the practitioners that we work with are very familiar with traditional quality improvement processes and practices, but not as familiar with implementation science. And so that way we could sort of embed the implementation science into some of what they already knew.
We're going to be doing like the shuffle between each modules and stuff. So we're going to start off walking through the QIPI A3. So starting off with the first box in the upper left-hand corner, we need to define our problem. So the problem also needs to be measurable, feasible, and don't get ahead of yourself by identifying a solution, since your idea of a solution may not be the appropriate one. But beyond just what the problem is, you also need to understand why it's a problem. Does it affect disease prevalence? Does it affect mortality or morbidity? Or is it costly to the system? AHRQ defines 6 domains of healthcare quality, and we want to map how this problem impacts these domains. So what are its consequences? Does the problem affect patient safety, the effectiveness of our care? Does the problem create less patient-centered care? What about the timeliness to respond to this situation or events? Is the problem impacting efficiency in our healthcare system, or is it further contributing to health inequities? Central to healthcare quality improvement, we are mapping our problem to the points of the quadruple aim. What is the effect of the problem on population health? How does it contribute to healthcare costs? And how it contributes to the patient experience, but also looking at that as kind of the intersection of quality of life and symptomatology. And finally, the updates of how the updates to the quadruple aim have also included clinician well-being as being a critical domain for healthcare quality. So then an important aspect of identifying the problem is also understanding who is involved in this problem. We have another toolkit we use in the program that is also commonly used in program management workflow. Call it the RACI, responsible, accountable, consulted, and informed. And this helps determine which stakeholders are relevant to the problem and at what level they should be involved with problem identification and their necessary level of engagement throughout the process. So these may be clinical staff, patients, but then understanding in what capacity they engage with patients, which patients, and then also considering administration, such as your C-suite, compliance, QI individuals.
All right, and then we gave everyone the QIPI A3, so you can also follow along on the handout there as well. So once you've identified the problem and you have your team together and the team is all on the same page about the problem, the next step is really understanding the current situation. And so that's this box on the QIPI. So for quality improvement, results are often mixed and very difficult to replicate. What works in one setting may not work in another setting, even if they're the same type of setting. So for example, a critical care unit here at Children's Mercy has a very different context than a critical care unit in a community hospital out in Western Kansas. So it's important to understand that just because you've had an intervention that's worked in one setting, it might not work in another. And understanding that context is crucial to project success, and some things to think about are the type of intervention being implemented, the stage of development of the intervention, your stage of implementation, The level of the system that you're targeting, and then specific components of the intervention. One example that I give, before getting my PhD, I worked in quality improvement in the Cleveland Clinic health system, and I had intervention to reduce collapses that I implemented in one of the Cleveland Clinic's community hospitals. I did it the exact same way in another hospital that was only like 10 miles away. And the uptake and the results were vastly different. And a lot of that is because I had training in traditional quality improvement, which doesn't take into account as much of sort of the context and culture. So some methods of context assessment that we talk about in the TIARA program are things like just observation, observing what's going on, interviewing the people who do the work and are involved in the work, surveys and validated instruments. There's a lot of validated instruments out there depending on what you're looking at. There's organizational readiness for change, a lot of teamwork, assessment tools. AHRQ has some really nice safety culture assessment tools. Using baseline clinical data, doing document analysis, so looking at things like policies and procedures. It's always interesting to look at policies and procedures and then look at what people are actually doing. Looking at information that's shared with staff, mission, vision, values, annual reports can be good assessments of context. One thing that we spend a lot of time on in the TIARA program is thinking about mapping out the workflows and processes. So process maps visually represent a workflow to help better understand that process. There's different names depending on sort of the background of the folks you're working with. Some people call it flow chart, flow diagram, process flow chart. But basically, all of those outline individual steps that are involved in a process. It's helpful in communicating processes, but it also can help reveal areas of improvement. It usually starts pretty high level. Like when we do these, we'll talk to people and we'll get sort of a general idea of the workflow. And then we talk to more people and sort of refine it and make it more and more detailed. This is an example of one that we did for an opioid project in the Kansas City region.
So now moving on to the target section of the quiz. So again, you see that third box down. So when thinking about our definition of the target or our goal, it's really necessary to have a clear parameters on what we are. What is the sample size you are looking at, and how does it relate to the larger population proportion? Are there specific inclusion and exclusion criteria to consider for the population you are targeting? But most importantly, you want to make sure your goals adhere to SMART guidelines. So SMART stands for specific, making sure that the goal is straightforward, easily defined, to the point, that it is measurable. That points of reference to ensure the ability to measure towards the goal. That is attainable. Be realistic in what you're trying to do and feasible in terms of the resources that you have, such as time, staff, skills, funding, and support. That it is relevant, that this goal is actually important to those, and that it has appropriate buy-in from the team that you're working with. And then also timely, within a specific time frame for accountability and project management.
So next, we start thinking about our evidence-based interventions. This is this box here. So for evidence-based practice interventions, really the focus of implementation science and QI is on putting interventions into practice. Whereas a lot of clinical research is more often focused on developing interventions. And we've worked with teams that have wanted to put in place interventions, but the interventions just didn't have much of an evidence base yet. And so at that point, we've recommended to them that they do efficacy studies first, or at least some pilot studies, before moving to putting interventions into practice. So we really want evidence, interventions that already have an evidence base. So at this stage, the goal is to identify at least one evidence-based intervention or practice that could work for this problem, and that could sort of work within this context and with this team. And then you can sort of select the best one. If you have more than one, you can always use them to create a bundle. So for identifying evidence-based practices, there's a lot of different ways to do this. A lot of information and systematic literature reviews. Some of the teams that we've worked with, especially in community-based organizations, have received a grant to implement a thing. And so they sort of have a already packaged intervention that they've been tasked with implementing. And then practice guidelines are another good place to start. And on a practical level, context is also really important here. Different groups, different professions, even different subspecialties in different sites may have different standards for what they find to be acceptable levels of evidence. We've worked with an intervention in the emergency department. One emergency department physician group that we worked with, because the intervention was based off of a randomized control trial in Canada, they didn't feel that was really appropriate for the US. Whereas we've worked with an emergency department group at a different hospital that was totally fine with the level of evidence for that particular intervention. So it's important when you think about acceptability to think about sort of what level of evidence the group that you're working with sees as acceptable. One of the tools that we use at St. Luke's is the EBP-IAA, and that helps us to determine sort of the appropriateness of the intervention. So some things that we think about are expertise in clinical champion. So do we have a good clinical champion for the intervention? And that's really turned out to be key in all of our studies so far. And then stakeholder participation. So do we have relationships with stakeholders to ensure project success? And then for population, is this a frequent or severe enough problem at our institution? We've had particularly residents or students who've come to us wanting to do projects on things that just aren't, they don't have a large enough patient population for them to be sort of worth the resources to be able to do. Oh, I realized that these were. And then organizational capacity. So is there enough capacity in the setting to be able to carry out the project? So is there enough financial resources if that's something you need? Enough staffing resources to be able to do that. And so then based on that information, we think about sort of the value versus effort. So if something is high effort and low value, that's something that we avoid. If something's low effort, low value, we sort of investigate it further to see if there's ways that we could increase the value. If something's high effort, but also high value, we might consider that in the future when we can have more resources to support that effort. And sort of the sweet spot is the high value, sort of low effort. And when we're thinking about new projects, we actually have the team members rate the different criteria on a scale. And so we can sort of think about that.
Looking at determinants, so the bottom box there on the Quippy. Dr. Estabrooks did go over a little, he touched a little bit on determinants, so they didn't go too in depth about
No.
determinant frameworks this morning. So again, seeing this little flow chart here. So within implementation science, there are several different types of frameworks that can help you to define, plan, and assess your implementation project. Typically falls within these 5 domain areas. But for the purpose of TIARA, we are mainly focusing on the process models and determinant models and evaluation frameworks. So yeah. So determinant frameworks do have a specific purpose to characterize factors that might influence implementation outcomes. They, however, do not specify the mechanism of change and typically operate like a checklist of determinants at multiple levels. So determinant frameworks are often are very useful in defining both the independent and dependent variable influencing the implementation outcome, and they can draw links between dependent variables and can highlight barriers between variables that hinder their interdependence and therefore have that impact on implementation. So there are several different types of determinant frameworks in the literature, and some are more appropriate than others based on your level of analysis, the setting of your implementation problem, and how much prior knowledge is known about your context. So for example, I know Dr. Estabrooks mentioned about the CFR framework. There's also the Paris framework. So CFR stands for Consolidated Framework for Implementation Research. I see this often used in understanding barriers with facilitators of an implementation problem. Paris framework is promoting action on research, implementation, and health services. And then the theoretical domains framework. I would say that one's a little bit more based on like individual behavior change. And so, yeah, behavior change to investigate implementation problems. So probably would be used more kind of like on an individual level assessment. So the one that we're going to highlight here is actually the tailored implementation and chronic disease, which is a commonly used determinants framework. Okay. Determinants of the implementation problem can be uncovered through a variety of assessments. Very similar to kind of the context assessments that Danielle was talking about. It can be through the application of process maps, interviews, observations, or baseline data assessments can provide adequate evidence for determinants. And then there are also several traditional quality improvement tools such as fishbone diagrams, Pareto charts, and more to also help identify the appropriate determinants. So within the TIARA program, we also use this chart, DART, the determinants and root cause table, to really help you map out these determinants against the constructs of our determinants frameworks. So in the example here, you'll see on the first column, the determinants identified within the constructs of that tailored implementation for chronic disease framework. And then next, from our context assessment or our QI tools, we were able to provide some evidence of these root causes. And then the next steps look at strategies to best address these determinants, which can help identify the appropriate intervention. Okay, so again, yeah, here's an example of the constructs that were filled out for the evidence as demonstrated through qualitative assessments that it maps against these constructs. I believe this is for the code HF.
Yeah, that's code
HF.
So
yes, it's a heart failure intervention. So see there on the left, those are some identified factors. Then in the center, some of the root cause. It looks like it was done through a qualitative assessment. So we have some direct quotes from those interviewed. And then passing through the Danielle.
So then we sort of move into recommendations and strategies, which is thinking about implementation and strategies is defining the how. So we think about these as approaches or techniques used to enhance the adoption, implementation, sustainment, and scale up or spread of an innovation. And they play a critical role in delivering the intervention and define the how of delivering and carrying out what we're going to be implementing. So in the TIARA program, we frequently use ERIC strategies. And if you were in Dr. Estabrooks' workshop earlier today, as he mentioned, there's 73 of these. So it's quite a long list. This is just part of it. We can also think about discrete versus multifaceted strategies. For example, a discrete strategy under the category of education could be educating primary care providers about the benefits and evidence to support the use of buprenorphine in primary care. Whereas multifaceted might involve education and a registry and clinical reminders. So at this point, our teams have identified the problem. They've identified some potential evidence-based interventions. They've used a determinants framework to map out some of the facilitators and barriers to implementing the intervention. And so then we work with them on identifying strategies for implementation to overcome the barriers or leverage the facilitators. And so in our DART tool, that's this box that we work on. So the intervention is the practice that will be implemented, and it could be programs, policies, procedures. And then the strategies are the methods that are used to support the adoption, integration, and sustainability of a practice. And so for this example, you have your using the TICD, because that's what we selected for this heart failure project. We have the determinants on the my right, your left. And then from our qualitative interviews, we have the evidence of those determinants. And then we map those to strategies that could help overcome those barriers. And then based on that, we take our intervention and we map out specifically what we'll do with the implementation. Which then brings us to implementation.
Going to our second to last box. So we need to develop our action plan and identify what implementation outcomes and measures are most pertinent to our problem and how we can measure them. So we can use traditional QI frameworks. One, the plan, do, study. I always want to say see. It's not see, it's study. To assess the outcomes of our implementation. So we want to understand how strategies contributed to that successful implementation outcomes and measures definition. So this is going to be different from the target or goals that you previously identified. As assessing implementation outcomes can help you better understand the implementation itself. Proctor and colleagues, it's cited down there. I believe it's so on the back of your quippy. We also have a list of resources. But Proctors and colleagues identified a series of constructs in which we use to assess implementation outcomes. Dr. Estabrooks did talk about this today, and I think highlighted how some different opinions about what are constructs, what are evaluation outcomes. But implementation outcomes are the measure of implementation success, the proximal indicators of implementation processes, and key intermediate outcomes of effectiveness. So the key value of implementation outcomes is to distinguish the difference between intervention failure versus implementation failure. And so these are some of the key implementation outcomes that are often measured during implementation studies. So in TIARA, we use the SIM-PDSA, which is Strategies, Implementation Outcomes, and Measures, Plan, Do, Study, Act, to help us map our strategies to appropriate implementation outcome measures and plan how we're going to do the intervention, study the intervention, and act on lessons learned from that intervention. So you'll see left-hand side example of a strategy that we use from our DART tool. So conduct ongoing training with frontline staff. So within the SIM-PDSA, we identify our implementation outcomes and determine operational definitions and how those will be measured. So then in that second column there, we identify two main implementation outcomes that we were interested for this particular study. So looking at adoption and acceptability. And so those measures are defined by education rates, so how many clinical staff are educated on the intervention, and an assessment of their understanding and knowledge of the intervention to measure providers' acceptability and the utilization of this tool. So then we move on to the plan column. So who is doing what, when, whom, how, and this is where you will describe your data collection plan. So you'll see we indicated who in our study team is collecting the adoption and acceptability data and at what time points those data collection are happening. And then we move on to the do phase. Then documentation is critical, especially if modifications are made. What may seem insignificant to you as a researcher or practitioner may be the key piece in how interventions are best delivered. So this is obviously a simplified version, but shows how the progression of trainings delivered and noted what types of modifications were implemented to improve that implementability. So when you are recording your modifications, we do encourage you to use this frame table. Again, another tool used in TIARA. However, this frame table is from a paper. It's an expanded framework for reporting adaptations and modifications to evidence-based interventions. This is also publicly available online. And so then finally, the study. So we're analyzing our results and summarizing our findings and comparing those to what we had predicted initially. So you'll see here what our results were of this education program and understanding and knowledge of the program. And then finally acting, determining what we're going to do with our next steps of whether adopt, adapt, or abandon. So again, you'll see this last column here about what we are planning to do with the information that we learned. So what do you do with these results? Generally, there are three options. So adopt, what does it mean? Which means that you then want to consider sustainability factors and prep your intervention for sustainment. Adapt, as mentioned before, utilizing the frame table to document your adaptations and reuse the SIM-PDSA to understand if your adaptations make the implementation more successful. And then finally, abandon. We often so focus on the importance of successful outcomes, but oftentimes knowing what something doesn't work is just as successful. And this actually leads to some de-implementation concepts that may come into play, but that is a whole other lecture in itself, and we don't even touch on it in TIARA.
Oh, I just want to mention like one thing. This, so I found this flow chart is really good. I found it to be really helpful. It's the Rhode Island, the REL Northlands education group, and I have the URL down here. Anyway, it's a really good resource. So back to sustainability and follow-up. So the last box of the quizzy A3 has to do with sustain and follow-up. And sustainability is an implementation outcome, but it really sort of cuts across service outcomes as well as client outcomes. So there's a lot of challenges with sustainability. In a review of 10 years of implementation science research, of the implementation outcomes, sustainability was only looked at in 15% of studies. And the dependent variable to test implementation strategy effectiveness, sustainability was in less than 5% of studies. As we mentioned earlier, there are evaluation frameworks of having yield sustainability, the PSAT, REAIM, as was mentioned this morning, Precede Proceed is one that I've used in the past, and PRISM, which was also mentioned this morning. So when we think about scale and spread, if you get to the point where your intervention works, you'll know at that point that change is hard. And so having a blueprint and thinking about multipliers in your pipeline and how difficult it is to replicate in other settings. For scale up, replicating and extending the reach of intervention into other localities, cities, regions. It could also be other units or hospitals or healthcare systems. And thinking about building infrastructure to support full-scale implementation. And then when we think about spread, you're thinking about replicating the intervention. So for dissemination planning, tailoring your message to different audiences, and thinking about the modes of dissemination. You know, a lot of implementation research is done in different settings. And so thinking about who the audience is, who the recipients are of that, of your dissemination, and sort of understanding what you did in your results. So some things you can think about are partnering with community professional societies, doing town halls, social media. We often put together a table when we're planning out our studies in advance of sort of what audiences we want to reach and how. Summary.
So again, just gone through our QIPI, our Quality Improvement Project Implementation A3 framework. As we mentioned, this is just one of many tools that the TIARA program utilizes, but this can give you a nice framework about how to address your implementation problem and the ways to work through it. And so just in summary, as Dr. Estabrook's nicely highlighted the timeline about the diabetes prevention program, is that unfortunately, like, it can take 17 years for evidence-based interventions to enter into practice. And translating that evidence into practice in communities is really hard, I think, as you're all familiar with. And so our hope with the TIARA program is that we're really trying to marry the ivory tower implementation science with a little bit more of a pragmatic real world quality improvement approach. And so TIARA really provides those tools and frameworks necessary to implement change more effectively and systematically to maximize that impact. And so we still have about, I think, like 10 minutes left in our session. So happy to go back and focus in on certain sections or any just general questions about the program or just the use of the QIPI A3.
What are your thoughts about Paul's, like you heard, he said he doesn't believe in determinants.
Yeah, that's a good question. I think determinants seem to be still sort of widely used in the field, and for our purposes, because we really focus on pragmatic practice, I think when you start getting into nuances, it gets really hard for our teams to be able to think on that level, you know, because they're all novices at this. And so even thinking about, for the teams that we work with, thinking about barriers and facilitators ahead of time is already a really big step. The vast majority of QI is, here's a problem, here's what I think will work, let's go, without really any assessment of context or thinking about the implementation like at all. It could be that we eventually get to a place where, you know, they have enough experience at this that they can sort of start to think about the nuance. And certainly from a research perspective, you know, I was even thinking about when Paul was talking about mechanisms, like we don't even really get into the weeds of strategies versus mechanisms. And so with our teams, maybe as they gain more experience, you know, being able to sort of think through some of those things would be appropriate. But at this point, we're just at the stage of helping to make regional quality improvement initiatives like actually work.
I'm also concerned that when he was talking about context, strategy, mechanism, and outcome, like it hasn't been published. No.
Yes. Yeah, I was actually wondering that when he was talking about
Yeah.
it hasn't been published yet. I was gonna look
I
and
asked
see.
him.
Okay.
Yeah, I said, I can't find a reference for this.
Yeah.
Yeah.
I think it's important to keep in mind, like implementation science is an interdisciplinary field that evolved from like a lot of different fields, like both the public health, the sociology background. So I mean, there's a lot of borrowed terms, and I think we're still trying to work out what those terms are. I can see Paul's point about like not determinants. I can see that there's probably, you could make an argument of overlap between context and determinants,
That's like,
being essentially the same thing. But I think, yeah, as Danielle mentioned, just like kind of trying a pragmatic approach to getting people to understand, like talking about facilitators and barriers, is, in my experience, just been a little bit easier for people to grasp sometime, when trying to apply this in a practical way.
And I think there's still a lot of room for, that sort of higher level, more sort of pure science, sort of academics, like working through a lot of these things. I think there's sort of a continuum of people who are sort of pushing the boundaries of the theory and the science, and then the people who are like using it in practice, and sort of a wide continuum along there. And in the TIARA program, we don't get into that level of depth, but we do in the live learning labs provide more, because this is pretty general. And so in the live learning labs, we provide a research, more of a sort of a typical research example, as well as like something that's more like pure QI. So we sort of take either end of it in the live learning lab, and after people have had sort of the content, we go sort of in the directions.
I'm glad you mentioned the implementation science as a spectrum, because I think that's where people get really like scared and overwhelmed and stuff. And so just like a reminder, like Dr. Esterbrook's here today, he was part of the team that developed the REAIM framework, which is like a highly utilized framework in a lot. So like he is a implementation science methodologist, like that has been his background, and like that's wonderful. But I think like especially with TIARA, we're trying, like the TIARA program isn't trying to make you methodologists. Like it's not equipped to do that. There are other implementation science training programs through other institutions that I would recommend if that is the direction you want to take. What really TIARA is trying to do, again, like the practical approach of utilizing these frameworks and strategies to be actually able to apply it into your everyday practice. So I would say like TIARA is kind of like that middle stage of the continuum. Like I would say the people over here on the left, like I've heard of it, like, okay, great. But then like the middle here is like, okay, I've heard of it and I want to use some of these concepts like in my work, but like, I don't want to be over here, like talking about methods and arguing about frameworks all day.
another question about, have you done this in person? Or have you?
Yes.
Oh, okay.
Yeah.
What is the difference in terms of, I don't know, you've already looked at the data, the evaluations, like in person versus online versus self-paced?
Yeah, so I will say we have much less data on the self-paced, because in all honesty, people in the self-paced tend to linger and not complete it. Which I think is just sort of human nature when you sign up for I've done it myself. You sign up for some sort of online training program and there's like no deadlines. And so you're like, nah, I will get to that when I have time. The feedback on the in-person and the sort of live synchronous has been the same.
Okay.
Yeah.
And when you do it in person, is it one day or how many?
It is two full days. When we've done it in person. And we've only done it in person for organizations just because we haven't found enough desire for people to sort of take 2 days off of work to go sit through 2 days of content. We found that for busy working people that the watching the pre-record, because our modules are each module has an hour worth of videos, but those are broken up into like 15-minute chunks so that when people have a little bit of time, they can watch one or two. And then each one also has an hour worth of reading. And then there is they actually complete the QIPI A3 sort of as you progress through the modules. And so there's that work as well. And then the live learning labs are every other week at noon, where we provide the highlights of the modules, but then we also do the research and the QI examples, and then we have time for sort of discussion of the problems that we are having. What's interesting about doing the workshop in-person version is that there's actually less time to do sort of the discussion on people's projects, because it's like you get a lot of content in a short period of time. It's just sort of less time for people to sort of think through the content instead of having like 2 weeks for each module. Sort of pros and cons.
Y'all have people from outside of KC who do it online?
Oh, yeah.
It's nationwide?
Yeah, nationwide is open.
Yeah, in fact, right now we have a couple folks at University of Wisconsin,
Awesome.
a couple folks at University of Utah.
There's a unique significance of this program nationally.
Yeah. So we've advertised it through the CTSIs, and so we've had people from sort of all over. Yeah, I've had some people from Cleveland.
I'm trying to go back to the map at the very beginning of the shows where.
Oh, I must have missed it.
Yeah, no, it was like one of the very first slides that shows where we've had attendees, but I don't think we've updated that with this year's.
No, we haven't updated it. We have a graphics guy at St. Luke's who does some of our graphics for us.
Wow, you guys went through a lot.
95 slides on here.
That's interesting that the in-person, you actually have less time. Yeah, because I would expect it a little bit more like in depth because you're in person, but it actually like.
It's actually less.
Yeah,
it's actually a bit less. Yeah.
So the yellow shows where scholars have come from.
Very cool.
And then in our recordings, we do have people at we have someone from Hopkins. We have Mark who does a lecture. Someone from Dartmouth who does a lecture. So we also have some guest lectures in there as well. So that's not like the Danielle and Stacy show. Break it up a little bit.
Also, for the record, Stacy is in Belize with her family now. She was the one who volunteered us to do this, and then she's like, "I'm gonna be in Belize during that time." So I'm like, "Okay."
Put the modules up,
What?
the module listing.
So the one thing we didn't talk about here that we add on is the future of implementation practice. And so in that one, it's a little bit of a potpourri. So we have like a ethics sort of IRB talk. We do an equity one. And Ann Sales does, she does a talk each year for us on sort of where the field is sort of going. So that's in that last one as well. I think we are, yeah.
Thank you.
Thank you,
everyone.
Last group.